Hi, everyone, and welcome. We're so happy to have you joining us today. I'm just going to give this a few more seconds for everybody to be let in from the waiting room. But thank you all for being here with us today. I'm Kath Stevens, social media manager here at Within. I'm excited to introduce today's session with Chrissy, how to talk about the medical side of eating disorders when I'm not a doctor. I'm just going to get us kicked off with a few housekeeping items. If you have any questions regarding certificates, session recordings, if you have any technical difficulties, I'll put all the necessary contact information in the chat. That way, you'll know who to contact if anything comes up. And I will also put in the chat the details for our next webinar session that's happening next month, and I'll include the link if any of you would like to register for that session. Um, and just as a quick note, while we don't share slides, there will be a recording of this session available to you in your CEGO dashboard after the conclusion of the session within 24 hours. So if you'd like to, if you missed anything or want to, go back and review something, the video will be there in your dashboard for you. And now I'll pass things off to Erin, who's going to kick us off with some introductions.
Yes, thank you, Kath. I appreciate it. Hi, everyone. I am Erin Kowalski. I'm the VP of Ecosystem Strategy. I'm going to fill you in a little bit, a very broad overview of Within, and then we'll get going. So Within, I'm sure most of you are familiar with us. We are an intentionally remote PHP and IOP program for eating disorders, anyone from the ages of 13 and up. We're the first to be doing this. We are intentionally built to be in this space. I always like to highlight a quote from our co-founder, Dr. Wendy Oliver Pyatt. It stayed with me since I started 4 years ago. For some patients, being home and being in treatment is really powerful, right? So we get to really change the landscape of how we're providing higher level of care for eating disorders. And we're doing so in a way that is very enhanced. And we use the word enhanced, there's a lot of meanings behind it. So some really interesting nuances to our program is we have a food delivery incorporated into every patient's treatment program. We do medical remote monitoring, right, to make sure that we're treating our patients effectively from a medical standpoint. Scheduling is unique. Every patient that comes to us has a schedule planned treatment around their day to day. It's a very livable program. So working through a lot of the barriers that our patients see of, I can't go to care because, right? We get to work through a lot of that. We do treatment in short stints, 1 to 2 hours at a time to really make sure our patients stay engaged and then also can, be active in their day-to-day life. And then my favorite, we have a virtual living room. So there's so many more touch points that we get to experience with our patients. There's so much hand-holding involved. That's open from 8 a.m. to 10 p.m. every day in a patient's time zone. So if you are interested in learning more, I co-host with our director of family admissions every Tuesday at 12 Eastern, a Discover Within for potential patients and partners and providers to learn more. So that flyer will also be shared. So always feel free to join. It's a fun time. We love being there. And now I have the pleasure to introduce Chrissy Stockert. She's our Chief Health Officer at Within. And lucky for her, she lives in sunny Miami, Florida. Chrissy's journey in healthcare started after a career as a teacher, which you will definitely pick up on her ability to present. And she still loves to bring education into the work that she does every day. After becoming a nurse in 2010 and working in various specialties, she found her passion and has dedicated the past 15 years to specializing in the field of eating disorders. She feels honored every day to work in this field and with this population. Beyond her professional endeavors, she's a proud mama bear of two wonderful and beautiful children. She loves to go to their school plays and cheer on their soccer games. I mean, little kids playing soccer is by far the cutest thing in the world. When she's not chasing around her little ones, you can probably find her baking, reading, going on long walks on those beaches. And because she's a huge nerd, she loves doing crossword puzzles. So without further ado, handing it over to my good friend Chrissy.
Thank you, Erin. It's my pleasure to be here with everybody today. I'll just preface a couple of things. I am going to be looking at you, but my screen that I'm sharing is on a different computer or different screen monitor. So if I ever look to the side, I'm just trying to make sure that I remember that I need to actually change the slides. Occasionally I'll forget. So someone can pop in and be like, I think you forgot to change the slide.
I gotcha. Don't you worry.
Thanks, Erin. Okay. And so today we are going to talk about how to talk about the medical side of eating disorders when I am not a physician. So one of the things that I have seen happen over and over again is a patient of ours will go to their doctor. They will get some kind of test result or lab result or any kind of information from their medical provider. That medical provider will say, do you have any questions? And they are a deer in the headlights and say, nope, I'm good. I'm good. And then they're going to go to their therapist a day or two later and download everything to their therapist, who's like, but I don't necessarily know what any of this means either. And so I'm going to talk about some of the common things that our patients experience, give you the basics of them, what's actually going on inside of the body, so that you can leave with a little bit more understanding of it and hopefully have some takeaways of this is what I can say, this is how I can navigate it. So we are going to specifically go through describing the basics of lab abnormalities or a lack of abnormalities and how to talk to an eating disorder patient about this. We'll look at the pathophysiology of hypoglycemia, how to talk to an eating disorder patient about it, the pathophysiology of bradycardia, and how to talk to an eating disorder patient about it, the pathophysiology of amenorrhea, and how to talk to an eating disorder patient about it, and the pathophysiology of bone density, and how to talk to an eating disorder patient about it. So jumping right in, we're going to start with the blood and lab changes. And one of the things to always remember when we're talking about the body is that the blood wants to stay stable. It is going to fight fiercely for that to happen. So once things become abnormal, it's a very clear sign that the body is struggling. So if we start with a couple of them, sodium. Sodium is one of the common ones that we see. If you get a CMP done or even a BMP, sodium is going to be the first thing that pops up on that list. So in most labs, a normal sodium is somewhere between 135 and 145. A sodium that is too high or too low is dangerous and can lead to things like headache, confusion, drowsiness, restlessness, irritability, muscle weakness, seizures, coma, and in severe cases, death. And in eating disorders, we will often see hyponatremia. So hypo is low, natremia is salt. So we see a sodium that is often below that 135 mark. And we'll get into the specifics of what that looks like in another slide. Another one that we see is potassium. So typically a normal potassium is going to be somewhere between 3.5 and 5. And again, a potassium too high or too low is really dangerous. It can cause fatigue, muscle weakness and spasms, tingling and numbness, heart palpitations, cardiac arrhythmias, and death. With eating disorders, this is an abnormality that is more closely tied to purging behaviors than it is to other eating disorder behaviors. So if someone engages frequently in purging, we will often see a low potassium. And so if that gets too low, it can be really dangerous. The way that I like to describe these is when we're talking, if we go back to sodium, the reason that we typically see a low sodium is that sodium levels in our body are much more affected by the amount of fluid that we take in than it is by the amount of salt that we eat in our diet. For me to have so much salt that I double my sodium value, I wouldn't be able to do it. My tongue wouldn't let me do it. My throat wouldn't let me do it. But I could easily dilute my blood by 50% by drinking a whole lot more water. My body will let me do that. So what we end up seeing is this dilution effect of the total amount of sodium overall is the same, but it's diluted in a much larger volume. And so we start to see those sodium numbers drop when someone engages in that water loading behavior. When we're talking about the potassium, like I mentioned, it's specifically related to that purging behavior. It can be purging via any means, though. It happens in purging via vomiting, purging via laxative abuse, purging via diuretics. All of those waste potassium and end up causing that hypokalemia, that low potassium value. Another abnormality that we'll sometimes see is a change in CO2, also called bicarbonate. When a bicarb level is high, it can cause tremors, muscle weakness, muscle twitching, lightheadedness, numbness and tingling in the face, hands, feet, or prolonged muscle spasms. Often in eating disorders, we see this when someone is engaging in purging behaviors, purging via vomiting, purging via laxative abuse. Oftentimes, what we don't see, though, is a value that is outside of the normal range. So that normal bicarb range is 20 to 32, and someone may have a baseline bicarb level of 24. If they have been purging, what we might see is that bicarb level increases to 29. It may not be out of range, but it's higher than their baseline. And so we will often use that bicarb value as an indicator if it's off from their baseline that they may be engaging in purging behaviors. The other one that we see abnormalities in that we watch very closely is phosphorus. So a phosphorus level, normal is 2.5 to 4.5. We don't really worry about high phosphorus levels, but when someone's phosphorus level drops and is low, which can happen with the reintroduction of food, it's very dangerous. It can cause muscle pain and weakness, confusion, irritability, seizures, heart failure, and death. And this is something that we see in the refeeding process associated with eating disorders. So if you've heard of refeeding syndrome, this is one of the key markers or key symptoms that can happen with refeeding syndrome. So phosphorus is something that we need in our bodies for bone strength, for nerve function, and for muscle contraction. About 85% of the phosphorus that we have in our body is stored in our bones, and the rest is stored throughout our body. When someone has been starved, those stores of phosphorus that are throughout the body end up being depleted very slowly over time. And that is actually okay. The blood is going to be able to tolerate that just fine. Overall, we have less phosphorus in our body, but our muscles are not contracting as much. And we can tolerate that with starvation. The problem happens with the reintroduction of food. So when we reintroduce food, that energy consumption starts to increase very rapidly, and we need all of that phosphorus that has been depleted. And if that phosphorus isn't there, then muscles can't contract effectively. And we have one muscle in particular that needs to contract roughly 100,000 times a day. And if it contracts inefficiently, it can end up leading to death because that muscle is our heart. So if our heart is not contracting effectively, that is called congestive heart failure. And we can end up seeing people die pretty quickly with the reintroduction of food. So with all of those baselines and basics, what do we hear our patients say? Very often, we're going to hear them say, it's not that big of a deal. I feel fine. How often have you had patients who say that? It's totally fine. I don't feel anything from it. So to start off, we have homeostasis. Homeostasis is our desire for equilibrium to remain. And our body is fighting fiercely to keep our blood looking normal. So like I mentioned at the very beginning, if someone's blood has become abnormal, it means their body is really struggling, and that cannot be ignored. So if they have hyponatremia, that low sodium that we have been talking about, and they say, it's fine, I feel fine, we actually have a lot of research that's being done right now that's showing that hyponatremia is actually never asymptomatic. So there was a study that was done that showed that patients who have asymptomatic hyponatremia are still at increased risk for falls, due to affected gait and have slower response times to visual and auditory stimuli. In one study that was completed in volunteers of similar age, after mild alcohol intake, attention and gait were less affected than those with hyponatremia. So even though people think hyponatremia doesn't cause symptoms, it actually is now showing that it does cause symptoms, and we want to normalize that sodium as quickly as we can. Hypokalemia, on the other side, when it is mild, it typically is perfectly asymptomatic. The problem is once somebody has that low potassium level, if they are still engaging in a behavior that will lower that potassium level even more, once it's severe, it can be so severe that it causes a massive arrhythmia and can lead to sudden cardiac death. It has very life-threatening consequences. So any kind of potassium that's abnormal needs to be addressed and needs to be addressed quickly. There may be instances when it is addressed by checking the labs again in a day or two, or if it's more severe, it may need to actually be replaced. And that would typically happen either with a pill or if you go to the hospital, sometimes with IV potassium. Hypophosphatemia, if it is mild, may be asymptomatic, kind of like the hypokalemia. But if it's not replaced, it can be fatal and can lead to really disastrous consequences. And so hypophosphatemia is not something that we want to just watch and wait for. So often what we will do is we are going to be looking at someone's lab values, and we're going to see what their baseline phosphorus level may have been. And let's say that their baseline phos level was a 3.5. If they are at high risk for refeeding syndrome and we get labs checked a week later, and that phosphorus level is now 2.9, technically still within that normal range, it's a significant drop from where it was before. And if it's dropping, it may continue to drop. And so we want to make sure that it's being replaced. And what your patients are going to come and tell you is, I don't want to take it. It tastes really bad. We need to take it anyway. Or I don't want to take it because it makes me really nauseous. You're going to take it anyway. Phosphorus is not one that we're going to mess around with. Phosphorus needs to be taken, and those supplements need to be taken if those have been ordered by your provider. And something that I also always want to touch on is, see, I'm fine. My labs are normal. So this is on the flip side. And this can fall into two different categories. So sometimes we have patients who are very sick and their labs are totally normal all the time. And they may have something like atypical anorexia, where they are not in a smaller body. They might be in a normal sized body, or they can be in any body. And their providers are saying things to them like, you're totally fine. All of your labs are normal. And it feels incredibly invalidating to them. See, I can't even do this well enough. And so one of the things that we need to really emphasize and make sure that we reinforce is that even if your labs are normal, if you have an eating disorder, you are sick enough. We don't need to see abnormal labs for you to feel validated that you have an eating disorder. Eating disorders are severe, and all eating disorders are deserving of full recovery. The other thing that we will often see is a common scenario like this. A client admits to us with normal labs and fully acknowledges that they have an eating disorder. 3 weeks later, their labs remain normal, and now the tune changes. I'm fine. My labs are normal. See, I can discharge. And typically what we're seeing happening is 3 weeks ago, they knew they had an eating disorder, and they knew that even though their labs were fine, they were really sick and needed to be in treatment. And now, feet are to the fire. The honeymoon period has worn off, and they're starting to, the eating disorder is starting to get cornered, and it's starting to fight back. And one of the things that it will latch on to is see, my labs are fine, I'm fine, I can discharge, things are good to go. And so that's when we really need to reinforce with them, actually, no, I think that this is when the work is getting really hard. And now it's time to really double down. And we can even call them on that. 3 weeks ago, you weren't saying this, and 3 weeks ago, your labs were normal. And so it's just a way that we can remind them that labs are not the be all end all of whether or not someone is okay. Because when eating disorders are threatened, they look for any justification to get away. And normal labs become a perfect target for that. All right. So next, we're going to look at hypoglycemia in eating disorders. The first thing we need to know when we're talking about hypoglycemia is what typically happens in the metabolic process. So when we have labs drawn, and it is a fasting lab draw, a normal glucose is typically somewhere between 70 and 100. But that is having not eaten anything. After we eat something that has sugar in it, that glucose gets absorbed into the blood. That blood sugar level will start to rise. That's going to trigger messages to the pancreas that say, hey, pancreas, release insulin, which out comes the insulin. The insulin works at a cellular level that opens a door. It's kind of like a key. It unlocks the door that allows glucose to then go into our cells, because inside of our cells is where glucose can actually do its job and give us energy. So we eat something, blood sugar levels rise, out comes the insulin, and in goes that sugar into our cells. And over the next couple of hours, that blood sugar level that was above 100 comes back down into its fasting range, somewhere between that 70 and 100. And then we have eating disorders. And we can really see two different things happen. One is what happens with eating disorders in a malnourished body. So in a healthy body, because you always have to start with what would be happening in a non-eating disordered body, I have about 2,000 calories worth of glucose stored in my cells, specifically in my liver and then in other cells throughout my body, in the form of something called glycogen. So if I eat something and my body releases insulin and all that sugar goes into my cells, sometimes the body responds in a way that maybe too much insulin was released. So all of this sugar goes flying into my cells and my blood sugar level starts to drop a little bit. When that happens, there is a whole cascade of all different kinds of things that can happen that tell my body to release the stores of sugar. So glucagon is released from my pancreas that tells my liver, release the stores of sugar. Up come my glucose levels, and I keep walking and talking, never knowing that anything abnormal has happened in my body. When someone is starved, those stores of sugar are eaten up and are depleted. And so the body has a much harder time keeping those blood sugar levels normal. So if anyone has ever experienced hypoglycemia, it feels very, very uncomfortable. And we'll talk about the symptoms of hypoglycemia in a minute, but just know that it is an incredibly uncomfortable feeling. And it is so uncomfortable that if you stop responding to those uncomfortable feelings, your body must think there is a famine. There is no availability of food. I'm going to turn off this system so that you don't experience the extreme discomfort of hypoglycemia and you don't feel so bad. So where my body would start to feel those symptoms of hypoglycemia somewhere in the low 70s, and I would be feeling very bad if it got into the 60s, someone whose blood sugar has consistently remained around 70 may not feel it at 70. Then it drops to 65 and they stop feeling it at 65. Then they drops to 60 and they stop feeling it at 60. So according to the CDC, a severe low blood sugar is below 54. Blood sugar that's that low can make you pass out. It makes you feel diaphoretic. You are sweating. You are confused. There's all kinds of things going on. And our patients have become so used to it that they are completely asymptomatic, walking and talking with glucose levels sometimes in the 40s. And prolonged exposure to hypoglycemia is not good for our bodies, which is why it's going to constantly be giving us those messages to raise that blood sugar. But if there's a famine, it's not going to. And so our patients end up with that same response and don't have those symptoms of hypoglycemia. There's actually a lot of research being done right now to find out if some of the deaths associated with eating disorders are actually from hypoglycemia. The other thing that we will see in eating disorders is something called postprandial hypoglycemia. So post-after prandial eating, hypo low glycemia sugar. It's a really big mouthful to say your blood sugar drops after eating. So again, this is a population where very often the stores of sugar are gone. So now this is a patient who has come into treatment. They eat something. That sugar is absorbed into their bloodstream. The body says, "Thank you for feeding me." It dumps out insulin, and it may have dumped out way too much insulin. So all of the sugar in the bloodstream goes flying into the cells, and now that blood sugar level starts to drop. And this is someone who may start to feel very symptomatic. Only it doesn't happen when fasting. It happens immediately after eating. And so the treatment for it is something that can be very scary for someone with an eating disorder. It is to eat a fast-acting carbohydrate. So someone who is diabetic and needs insulin always has to carry sugar around with them in case their insulin dose is incorrect. So you have sugar taps. You have half a cup of orange juice. You can have some jelly beans or Skittles or Sour Patch Kids are a favorite. And so it's something where that sugar is going to be absorbed very quickly to bring that blood sugar level back up to normal. Because when someone experiences hypoglycemia that is symptomatic, these are the kinds of things that they are going to experience. Sometimes they lose all their coloring. Sometimes their heart starts to race. Sometimes they feel really shaky, and they may hold out their arm and their hand might be perfectly steady, but inside it feels like this is happening. And sometimes they are physically trembling as well. They might be sweating, a cold sweat. They have anxiety, irritability, dizziness, headache, sometimes what we refer to as the impending sense of doom. Something bad is about to happen. And if you don't have an eating disorder, your body will naturally and your brain will naturally tell you, I have to eat something right now. But that system in someone with an eating disorder has been turned off, and that is not their natural thought process. And so they think it's just a headache or it's just my anxiety, because no one with an eating disorder ever has co-occurring anxiety. Or it's not that bad. Or my favorite, is this part of my meal plan? Or snack is in an hour, I'll just wait. And so these are all things that you may hear from your patients. And we hear it a lot from outpatient providers who work frequently with eating disorder patients, that they have snacks in their office because that hypoglycemia is such a common thing to experience. And so what we have to do is we have to make sure we treat the symptoms, because complications from hypoglycemia are confusion, loss of coordination, slurred speech, blurry vision, unresponsiveness, seizures, coma, and death if left completely untreated. But of course, this is a different population. So how do we respond? So when someone says, well, snack is in an hour, I'll just wait. One of the things that we can make sure that we are always reminding our patients of is food is medicine. We've probably all heard this a lot. We probably all say it a lot, but this is a prime example of food is medicine. If you wait an hour, things will continue to get worse. We need to treat it now. Another thing, well, what if this is just a headache? What if this is just my anxiety? Maybe it is. And if that's the case, in 10 minutes, we'll know. because if you drink the juice in 10 minutes, you'll feel a lot better. And I'll let you have the Advil or you can take your PRN. But let's start with the juice because often there's such fear around whatever is in addition to their meal plan that we need to remind them a little juice actually never hurt anybody. You can have the juice and you can have an Advil and you will still be okay. Or my favorite, it's not that bad. This is fine. This is how I normally feel. Well, what we're trying to do is we're trying to have people get that mind-body connection back and rebuild that trust between mind and body that may have been lost for a long time. And so what we really want is for someone to respond to what their body is saying. Their body is giving them symptoms, and now let's treat those symptoms. So one of the things that will often come up in this vein is, should someone be checking their glucose? And what we will often see is that people will then become very tied to numbers and will refuse to treat if that number isn't below 70. But symptoms can happen when the number isn't below 70. If I have just eaten something and my glucose level is 74, that is not normal. That is a glucose that is probably on its way down, and I'm probably starting to get that headache, starting to feel that sense of doom. And just because the number is 74 doesn't mean if I check it again in 15 minutes that it won't be into the 60s. And so we need to make sure that we are really encouraging our patients to treat a symptom and not a number. There is a large push right now, and I see it not just with eating disorders, I see it everywhere with the CGMs, those continuous glucose monitors. And we tend to shy away from those whenever we can, because we do see people get incredibly tied to those numbers. Now, there are some instances when it may be indicated. And obviously, if we're talking about someone who's a diabetic, that's a completely different world. But if we are talking about someone who just wants to track their glucose, we want someone with an eating disorder to be relearning to be in touch with their body and not have to rely on a device to tell them whether or not they're okay. The last thing that I will say is, if you have a patient who goes and gets labs done, and 2 days later, they're getting a phone call about a critical low glucose from their labs, and they're wondering, is this real? There is a high likelihood that that particular number itself is not real. If that person was up and awake and alert and talking to you, their glucose was not actually a 28. What we do often see, though, is that it is an indicator and a trend. So one of the things that we see is that when there are processing delays in blood, and even of 15 to 60 minutes, some of the cells inside of that blood sample will break, and that insulin that was inside of that cell will come out, and glucose will go into other cells then because of it. And so it shows these really falsely low glucose values that are done when they are done from a lab draw. And so we typically are not relying on that number as a reliable, accurate number of what their glucose really was. But what we will do is watch it as a trend. So if it was 28, that 28 probably wasn't real. But if a week later it's 32 and then 35 and then 38 and then start to normalize, what we see is that over time, that number is probably going back to normal. So that 28 may have actually been a 58 or a 60. It was probably still low, but wasn't at that critically low level. All right. Moving on then to our next body system, we're going to look at the heart and we'll look at bradycardia. So when we are looking at the heart and circulation, one of the things to remember is that our heart is one big circuit, and the heart itself, or sorry, our vascular system is one big circuit, and the heart is the pump of that circuit. Our heart has 4 chambers. We have 2 atria and 2 ventricles. And you can see in here kind of the direction of how everything flows throughout the body. Anything that's red is oxygenated blood. Anything that is blue is deoxygenated blood. So if we start in our right ventricle is going to send deoxygenated blood up into our lungs. And from there, it's going to come back oxygenated into the left atrium. From the left atrium, which is our holding chamber, it's going to go into the left ventricle. And from that left ventricle, it's going to come out of our heart into our aorta and go all throughout the body. Then the deoxygenated blood is going to come back up our vena cava, into our right atrium, into our right ventricle, back into our lungs, and that pretty figure 8 system is going to continue. So all of that pressure that pushes the blood out of our heart is the same pressure that is filling our capillaries at our fingertips and is the same pressure that's pushing it back into our venous system that's getting it back to our heart. And it all works together. And so when the body doesn't have enough energy, all of our systems, including our circulatory system, can slow down. And one of the ways that we look at this with eating disorder patients is we see a phenomenon called acrocyanosis. So acrocyanosis, if any of you have had children, when you were in the hospital, the nurse or the doctor who was examining your baby was going to do something called an APGAR score. And the A of the APGAR score is acrocyanosis. How purple are your extremities? So purple extremities in a newborn infant is completely normal. Purple extremities in anyone other than an infant is not so normal. And so what we see in eating disorders is that they are very often acrocyanotic. And there's a way that we can check how this circulation is going in someone with an eating disorder. And so I always do it by looking at something called capillary refill. So if you take a look, and you can all do this now on your computers if you're able to have your hands free, you can look either at your fingernails or you can look at the pad of your fingertip. And it's probably a nice fleshy color. And if you press down on it, it's going to turn white. All the blood is going to go away. And then when you let go, it's going to recolor itself and all of that blood is going to come back. When you pressed down on it, you manually pushed blood back into your venous system. And capillary refill is looking at how long does it take to refill those capillaries. Normal capillary refill is less than 3 seconds. So if I push down and it turns white and I let go, I want all that color to come back within 3 seconds. That means that my heart is pushing out blood with enough pressure that those capillaries can be refilled very, very quickly. What we end up seeing in patients with eating disorders is that capillary refill is not 3 seconds. It is 5, 8, 10, 12, 14, 16 seconds long. There is not enough pressure to refill those capillaries, which means there's not enough pressure to push that blood back to the heart. And then you see blood pool, which is why you end up seeing those purple fingers. It often happens when gravity is involved, which is why we see it in the extremities. So when someone stands up, gravity takes over, blood is going to fall and their feet are going to turn purple, or they stand up and their arms are down and their hands turn purple. We have a lot of patients who come in who will say, I've been diagnosed with Raynaud's syndrome. Raynaud's is an autoimmune disease where your body loses circulation in certain areas, often in the fingers, and you may have like 2 fingers that turn white. Sometimes they turn a dark shade of purple. What I have seen is that most patients with eating disorders who have been diagnosed with Raynaud's actually do not have Raynaud's. They have acrocyanosis from poor circulation related to their eating disorder. And when that eating disorder resolves and their body becomes nourished again, that circulation resumes normally and there is no sign of any kind of Raynaud's syndrome. With that, we have to take a look at the blood pressure. So blood pressure is another measure that we're looking at. So blood pressure by definition is the amount of pressure it takes to eject blood from the heart and then how much pressure is left in the heart when the heart is at rest. So we have two numbers in blood pressure. We have the systolic and the diastolic. The systolic is that top number. So when my heart contracts, how much pressure does it take to get that blood through the valve and out into my body? And then my heart relaxes, and that's the diastolic, the bottom number of how much pressure is left in my heart at rest. We in eating disorders are looking more heavily at the systolic blood pressure. There are other disease processes where cardiologists may be more concerned about the diastolic. We look more at the systolic blood pressure because what we will often see is patients under our care with eating disorders have something called hypotension, which is when that baseline blood pressure is low. And that is the body's defense mechanism. The body has intentionally lowered that blood pressure to say, I don't want to fill these capillaries very fast. What little pressure I'm going to give you is going to keep the blood closer to your vital organs because the functioning of your heart and your liver and your kidneys and your stomach is much more important than how well your fingernails are growing. It intentionally diverts blood to where it wants to go, and it controls that sometimes through our blood pressure. So somebody may have a naturally lowered blood pressure due to their eating disorder. And then what we see are sometimes what we call orthostatic changes. So orthostatic hypotension, which is when there is a significant change in blood pressure or heart rate when someone changes posture. So when someone goes from sitting to standing, you see either a significant drop in blood pressure and or a significant increase in the body's heart rate. And the reason that that happens is when I go from sitting to standing, gravity takes over, but I still need a whole lot of blood in my brain for it to continue to function. And if my body, for some reason, can't compensate quickly for that change in posture, I may lose pressure in my body. More blood is going to fall. My body couldn't compensate. It is so weak that just going from sitting to standing takes too much energy, and my blood vessels can't go like this to keep the blood going upwards. And so you see that drop in blood pressure. The heart then says, oh no, I've got to get this blood to the brain. So what's the only other option I have? Beat faster. So we see that drop in blood pressure, and then we see the rise in heart rate because we want to get that blood back up. When that's happening, someone can feel very symptomatic. So they can stand up and feel dizziness. They can stand up and they can black out. They stand up and feel tremendous pressure in their head. They may actually fall. And so we need to make sure that people are telling us about these symptoms and that they are then treating those symptoms if they are experiencing them. Because where all of us have probably been squatting down at some point, we stand up and we're like, whoops, I just stood up way too fast. And about 5 seconds later, we feel fine. This is happening to our patients all day, every day, and it lasts for sometimes minutes at a time, sometimes so severe that they stand up and then have to sit back down again. Or they may be in the shower and the heat expands their blood vessels even more. Their blood pressure drops. And I've had patients in treatment when I worked in a residential who would crawl out of the shower because they said something happened. I got really dizzy. I didn't want to fall. And so they got themselves down to the floor to be able to make sure that they remained safe. So that low blood pressure and then that drop in blood pressure with that change in posture is something that's quite dangerous. If someone were to faint and pass out, they would end up flat, ideally flat on their back. That removes the need for gravity because now our blood can circulate and blood gets right back to our brain. So logically, I understand why it may happen, but then there's also the risk of hitting your head when you fall, of something else happening. And so we don't want that to be happening. And so we're going to encourage hydration because there are a lot of things that can cause that low blood pressure. but the one really controllable factor that we have is hydration. So we make sure our patients are hydrated, and then with time and nutrition, we'll typically see those blood pressures normalize, that baseline hypotension may come back up. Some people just have a naturally lower blood pressure, but what we'll see is that those orthostatic changes stop happening. The other thing that we often see in our patient population is bradycardia. So bradycardia is the slowing of the heart rate. A normal resting heart rate, meaning you are lying down and being calm for about 10 minutes, is somewhere between 60 and 100 beats per minute, which is why, if you do the math on that, if it's 60 beats per minute, that's 84,000 beats a day. I mean, our heart is just going all the time. So that normal resting heart rate is somewhere between 60 and 100. When a heart is starved, it is going to try to beat less in order to conserve energy. So bradycardia is any heart rate that is below 60 beats per minute. And one of the things that we will often see is that this is reinforced by the medical community. So a lot of people will say, oh, well, you must be athletic, because athletes have very well-conditioned hearts that are so efficient that they can eject blood so well that they don't need to beat as often in order to perfectly perfuse the body. And so they may have resting heart rates that are a little bit lower than that 60 range. But what we see with eating disorders is that sometimes it's not in the 50s, and it might not even be in the 40s. It might be in the 30s, and that's when they're awake. So imagine what's happening when they're sleeping. And so here are some of the things that we then end up seeing that we have to help our patients navigate through. So very often, what they're going to come in and they're going to tell you is, well, it's okay. My doctor says I'm fine. So question number one that I would ask that patient is, did you tell your doctor about your eating disorder? Because a lot of times they may say things like, I run 5 miles a day. Not a lie, but they're also omitting the fact that they have an eating disorder. And so the doctor does not have a complete picture of what's going on. Maybe they have told their doctor about their eating disorder. So my next question is your doctor eating disorder informed? Because a lot of doctors still have a lot of bias and may not be eating disorder informed and may be giving a lot of misinformation, especially if somebody's body type doesn't fit the picture that someone is taught in medical school about what an eating disorder body should look like. And then the test that we will sometimes do with people is the get up and walk test. So if I were Michael Phelps and I had such an efficient heart that my resting heart rate was 40, and I got up and I walked across the room and I walked back, that heart rate of 40 would now be 44, because my heart is so well conditioned that did not take me much energy to get across the room and get back. Now I ask someone with an eating disorder, get up, walk across the room and walk back. And what we will see is that heart rate that was 40 or 50 may actually be 112 now. So that heart rate may have doubled, may have tripled, may have gone up, by more than 20 to 30 points. It took a lot of, and sometimes that just happens upon standing. It doesn't even happen with walking. That is not an efficient heart. There is a big difference between an efficient heart and a heart that is saying, how little do I have to beat to keep you alive? Two very different things. And so that's what we can talk to our patients about. I know I'm rolling through a lot of this really fast, so make sure that if you have questions, you can put them in the chat and we'll make sure that we get to them at the end. So next we'll look at sex hormones. And there are a lot of hormone changes that can happen. And the endocrine system is incredible in the way that it helps our body to stay alive. So if we are looking at the typical reproductive cycle of someone with ovaries, here is what it looks like. We have our hypothalamus up here in our brain, and that releases something called gonadotropin releasing hormone. That tells our pituitary gland, which is also in our brain, they're right next to each other, to release two stimulating hormones. Tells us to release FSH, which is follicle stimulating hormone, and to release LH, luteinizing hormone. Both of those travel down to our ovaries. The FSH and the LH then stimulate our ovaries to mature and then release an egg during ovulation. And they trigger that egg to release estrogen and progesterone. The estrogen and progesterone are going to surge. That's going to send a message back to the hypothalamus that says, stop with the gonadotropin releasing hormone, which will slow the FSH and the LH. And then once the estrogen and progesterone levels decrease, that gonadotropin releasing hormone is stimulated again. And we continue through this cycle. And someone with ovaries will go through that cycle somewhere between every 28 and 30-ish day, or 21 and 30 days for 30-ish years. And here's what it looks like on kind of in a picture with all different areas. So we have our ovarian cycle. We have our pituitary hormones that are going to surge right before ovulation. So we have the LH and the FSH that are going to, as they were rising here, they're telling the follicle to increase, to grow. It is actually ovulated. We have estrogen rising and decreasing, and then we have progesterone that is produced by this corpus luteum that is going to surge. And then as it drops, it's going to create, this is our uterus. It's going to build the uterine lining. And if there is no pregnancy or no fertilization, no implantation, then that uterine lining is going to shed when this progesterone and estrogen levels decrease. And I always like to leave people with something very tangible that they can take back to their patients. And sometimes I ask for a show of hands with this, but I can't actually see any of you. So I'm going to assume you all raise your hands when I say, who here has ever gotten constipated right before their period? Yep, right here. Our patients often feel very somatic when it comes to their GI system, and they will also experience that same constipation prior to their period. And every month it seems sometimes to come out of nowhere, and it will be very traumatizing, very activating for that patient. And what we can do is we can remind them that this is normal. The job of progesterone, which you can see surging right here, is to, among other things, relax our smooth muscle. Our uterus is made out of smooth muscle. And if we want it to be a nice, welcoming environment for a fertilized egg, we don't want it contracting. So it smooths that smooth muscle out, makes it nice and relaxed to welcome that egg. If no implantation occurs, well, okay, so then that progesterone works locally in our uterus. But the other thing that is made out of smooth muscle that is right next to our uterus is our large intestine. And so that large intestine gets nice and smooth and relaxed for a few days, creating less peristalsis, less contraction. And so we stop having bowel movements for a couple of days. Then that progesterone level crashes, we get our period. And if anyone is at all like me, then you get diarrhea, right? When you get your period and you're like, oh, and now things are back to normal. So make sure your patients know that this is normal. This is what should be happening in their body if they are getting their period. When someone has an eating disorder, though, there are a lot of changes that can happen with these hormones. So we will see things like low levels of that gonadotropin releasing hormone. We see low levels of FSH and LH. We see low and absent levels of estrogen and progesterone, and we see low levels of testosterone. And the way that you can tell the difference, because sometimes our patients are of a more mature age, is if you look at this FSH level. If someone is postmenopausal, you are going to see very high FSH levels because there is no estrogen that is trying to inhibit that gonadotropin releasing hormone. It's not blocking it at all. And so you're going to have very high levels of FSH. When someone has an eating disorder, though, their body is intentionally shutting down those systems. It is not trying to mature a follicle. It is not trying to utilize energy. If you've had children, you know that it takes a tremendous amount of energy to create a life and to keep that life alive afterwards. And this body is saying, you are not giving yourself enough energy, so I am not going to allow you to create another life right now. The uterus and the ovaries revert back to what looks like a prepubescent stage. The uterus regresses to its prepubertal length, and the ovaries revert back to their prepubertal size, and they may not even be visible at all on an ultrasound. With that, amenorrhea is common, but it is not universal. So amenorrhea is the absence of a menstrual period, and it can come in two different forms. You can have something called primary amenorrhea, which is someone who has never had a menses, never had a period in their life. Typically, that is somebody who is prepubescent, but you may have someone with an eating disorder where it developed early on in life and they have never had a natural period. And then you can have secondary amenorrhea. Secondary amenorrhea is when someone has had a period at least once in their life, and then based on malnutrition or some other factor, they no longer get their period. And this is common in eating disorders. We generally see it with restrictive behaviors, but not necessarily with low body weight. And so there are a lot of different things that our patients will say. They will say things like, well, I like not getting my period. And so if that happens, we have to explore why. There may be very physical things going on that feel very uncomfortable for them. They may get cramps. They may have severe mood changes. They may have that constipation. There may be trauma associated with it. Or if it's somebody who is exploring gender identity or is trans, maybe the idea of getting a period is very traumatic, very emotionally destabilizing for them. And so they may not want to get their period. And so if that's the case, we need to look at, once somebody resumes their natural menses, all kinds of other things that we can do to help control some of that. There's IUD, there are oral contraceptives. There are different medications that can help with some of the mood changes with PMDD. So it's important to explore the why behind it. They may say, I'm fine. My doctor put me on the pill. So thankfully, we are not hearing that as much anymore, but for a long time we did. So there was a false belief that somebody who was taking an oral contraceptive, which is a synthetic hormone, was fine because my bones were protected. Well, what we have found is that it in no way, shape, or form protects the bones. And some studies, though there is more research that needs to be completed, have found that oral contraceptives may actually have a negative effect on bone density, especially earlier in life and when there is estrogen suppression. And so it's something to be very cognizant of. If somebody says, I'm fine, my doctor put me on the pill, one of the first things we want to know is, why did that happen? Another thing we hear very often is, I got my period back, I'm done weight restoring. So there is a huge amount of variability in when someone gets their period and loses their period. I've seen people who have been above what would be considered an ideal body weight, even though there is no norm for what I would ever say is a normal body weight. who have lost their period, and I will see people who might be at below 60% of expected body weight and still have their period. Doesn't mean that they would be fertile, but for some reason, their body is continuing to create and shed that uterine lining. And so it's something that's been taken off of the DSM criteria for a diagnosis of anorexia. But a general rule of thumb, if somebody did experience amenorrhea, is that a general rule of thumb is the hormone cycle will return somewhere between 1 and 6 months after achieving 90% of expected body weight. And I want to emphasize that 90%. Again, it may be 80%, it's not a guarantee that it's 90%, but even if it is 90%, you are still 10% away from being done weight restoring. And there is a lot of hope that we have seen, because when someone fully recovers, what we don't see is that the eating disorder caused permanent infertility. But what we do see is that when someone says, I am only willing to go as far as the number when I got my period, is that they will likely be living with a functional eating disorder. And full fertility is not restored at that point. It is not as simple as I got my period back, I'm done weight restoring. We really want to see a push for full weight restoration, because there are also so many brain chemical changes in a positive direction that we see in that last 10% of weight restoration. And we hear the kind of the flip side of, I never lost my period, so my doctors tell me I'm fine. And again, this is similar to what happens with labs of, it feels incredibly invalidating to someone with an eating disorder to hear, well, you're totally fine. Like, stop worrying about this so much. Amenorrhea is a sign of the severity of an eating disorder when it's present, but it does not mean the eating disorder is insignificant if it is not present. It is not a two-way correlation. It is really only a one-way correlation. So much so that, like I mentioned, amenorrhea has been removed from the DSM as criteria for anorexia nervosa because of how inconsistently it appears. And lastly, today we're going to talk about the bones. So here's my little skeleton friend, and it's important to know what happens in the bones throughout a lifetime. So we are constantly throughout our life in the state of bone deposition and bone recalling. We always want fresh bones. And here's another fun fact. Every 10 years, you have a completely new skeleton. So I am 44 years old, and I am currently building my 5th skeleton, and I want my skeleton to be really, really strong. When we are younger, we are creating a lot more bone than we are recalling, with highest bone formation being peaking during puberty, especially in those like late puberty, early 20s. And then somewhere between 25 and 30 years old, we reach a state of equality. We are depositing bone, we are recalling bone, but they are in equal amounts. Our bones are their biggest, thickest, and strongest. And once someone with ovaries reaches that postmenopausal state, we are typically in a net negative, where we are recalling more bone than we deposit, and we may end up losing bone for the next couple of decades of our life. There are some things that we can do to help prevent that. And so what we will often see is diagnoses of osteopenia and osteoporosis, because what we see is that when those sex hormones go away, really specifically estrogen, when estrogen goes away, the bones are affected. Estrogen tells the body to deposit bone. It stimulates osteoblasts. Osteoblasts are the cells that tell our body to create bone. And so when those are suppressed with the lack of estrogen, we can see decreases in bone formation, or we see in someone who's much younger, much slower bone formation than they should be experiencing. And so we will often have our patients get what's called a DEXA scan. It's a bone density scan to measure the thickness of their bones. The diagnosis of osteopenia is some bone loss, and osteoporosis is severe bone loss. If you use the World Health Organization definition, It is a T-score. Osteopenia is a T-score between -1 and -2.5. And then a T-score less than -2.5 is osteoporosis. Those T-scores are compared to 30-year-old women who should have peak bone density. And so that's typically used for postmenopausal women. What we are seeing now is that much more often in our population, a Z-score is being used because a Z-score not only matches you to a 30-year-old woman, but it is going to compare you to someone of your same age, ethnicity, and sex. And so with that, a Z-score of -2 is now defined as low bone mineral density or sometimes less than expected bone mineral density. So we will see people that come in and they have a DEXA scan that was abnormal. So the question is, well, what does that mean? So what that means is that someone with lower than expected bone mineral density is at increased risk for spontaneous fracture. And the way that I always describe this is when I worked in a hospital, I was on an orthopedics floor. And I would have my little old ladies who would come in with a hip fracture. And my question would always be to them, did you fall and break your hip, or did your hip break and then you fell? And most of the time it was like, you're right. I was standing there. And then all of a sudden I was on the ground. Their hip broke and then they fell. And that is kind of the classic definition of osteoporosis. Their bones were so weak that they could no longer hold up their body. And while someone who is much younger may not be at such high risk as my, little 85-year-olds, that increased risk for fracture is there. So it means increased risk for stress fractures, no high impact activity. You were a basketball player, maybe not anymore. You want to go skiing? You can ski, but you can't fall. So are we sure that that's what you're going to want to do? And then the question comes in, well, what can I do about it then? Number one is to recover fully from the eating disorder. If weight restoration is necessary, weight restoring to not 90%, not some other fabricated number that you've decided this is what I'm okay going to, it's restoration to 100%. Of course, there you want to maximize calcium, maximize vitamin D. One of the things that we are seeing now is that bioidentical estrogen is being used much more frequently. So that is not an oral contraceptive pill. It's not a synthetic estrogen. It is actual estrogen that typically comes in the form of a patch. You wear the patch, you change it a couple of times a week, and that estrogen is enough to have a huge protective factor on the bones. And so there are lots of studies being done with eating disorder patients that are showing high protective levels with that bioidentical estrogen. If you have a uterus, you will also have to take progesterone because you cannot take estrogen by itself uninhibited. It will increase the risk significantly for uterine cancer. But with progesterone as well, there is no increased risk. Bisphosphonates or other bone stimulating medications are also sometimes prescribed. So that's things like Fosamax or Prolia. There's different ones. You probably see commercials with some older actresses who usually promote those. And one of the questions that we'll often get is, well, isn't high impact activity good for bone density? And the answer to that is, well, when someone is healthy, yes. So high impact activity is going to stimulate the bones to become stronger, to be able to absorb more impact. Or you're looking for muscle weight bearing activity, because if I have my arm here and I have my bicep and I bend my arm, there are insertion points. And when stress is put on those insertion points, it's going to trigger my bones to become stronger. But if I am in a malnourished state, that actually ends up having potentially a negative effect on bone density. So what can be helpful in someone who is healthy has the opposite effect in someone who is malnourished. So we are not saying to our patients, you should never move again. But we need to have conversations about when it's optimal to reintroduce it and to make sure, because movement is such a tricky thing with many of our patients, how to do it in a way that is not compensatory, not obsessive, joyful, in a way that you are promoting health and not further destruction. And on the flip side, we are also dealing with conversations like my DEXA was normal. So again, see, not even this is bad. My eating disorder is not that bad. I can go right back to my eating disorder because my bones have not been affected. What we can say is that bones will be affected. It's just a matter of time. And we don't know when and why, but 6 months from now, we may be having a very different conversation. So this is not a see, it's not that bad. It's a thank goodness my bones haven't been affected yet. And I have time to recover and be at no higher risk than I would have been prior to my eating disorder. We also see a lot of DEXA scans that come back with a Z-score of, let's say, -1.6. -1.6 is technically in that normal range. But for someone who has an eating disorder, I would look at that -1.6 with a tremendous amount of caution in saying this is totally fine and totally normal. It may be at a level where I'm not making movement recommendations and changes yet, but I am saying we need to stop this in its tracks because it is likely on its way down, and we can make sure that that gets reversed. And the younger you are, the more time you have to make up some of what was lost. I just flew through a whole lot of different topics. We talked about labs, hypoglycemia, bradycardia, amenorrhea, bone density. I know we have to wrap up in a couple of minutes, but are there questions?
Feel free to type it in the chat. I will see that. I know we had people popping off at one, so.
Oh, okay.
But let's see. And I know Chrissy left her information here. I will also send a follow-up email with my information and some other additional resources to have. And like Kath said, the recording will be on our YouTube channel as well, which will be helpful. Any questions? I'm looking. Question, Chrissy. Big question, but how is the 100% normal weight decided on?
That is a great question, and it is something that is very nuanced. So it really is kind of a multidisciplinary piece that's looked at. When someone is younger, we're often looking at growth charts because we want to see where someone was prior to the eating disorder. And if their growth chart showed that they were on, let's say, the 85th percentile their whole life, and then all of a sudden it dropped to the 25th percentile, we're going to probably look at getting them back up to somewhere around that 85th percentile. And then we'll have adults who may come in 40 years old and have had an eating disorder since they were 12, and we have no idea what that normal weight should be. We have IBW. That is something that people can always look at, but we feel like that is also just a starting point because it is wildly inaccurate, just like BMI for so many people. So if someone knows where they were pre-eating disorder, we would take that into consideration. We may look at how they're doing mentally. So are the eating disorder thoughts still incredibly strong, or have they started to quiet down? We typically see that once someone is past that 90% mark, those thoughts really start to decrease. And so there's lots of different factors that play into it.
And then, Chrissy, you have another really good question. Individuals with an eating disorder in a larger size body and normal blood work, what would be helpful for them to feel validated and express the concern for the eating disorder?
That is such a good topic. I feel like we could talk about that by itself just for an hour. And I think that it's so important to emphasize that everybody's body responds differently to an eating disorder. When I see someone with normal blood work, I'm saying, let's thank our lucky stars that it's normal and not think, gosh, I didn't do this okay. Every eating disorder is severe. Every eating disorder is worthy of recovery. And it's important to know that it has nothing to do with what symptoms or side effects you may have gotten from it to be able to say, this is an eating disorder worthy of recovery. They are all worthy of recovery.
And then another one, what would you or would you expect a rapid rise in heart rate in the walk across the room test in someone with an eating disorder who can tolerate running 5 miles per day as well?
We will often see that, yes. Mhm. So, that person with the low heart rate who may also be a runner, their heart is still compromised and we'll still see bigger changes than we would in someone whose heart has not been. So it may not double or triple, but for someone who is really that well conditioned, you would expect them to walk across the room and come back and it barely changes.
Another tough question is how does someone find an eating disorder informed doctor? So unfortunately, not as common and harder to find. At Within, we have outreach members throughout the country that we're connected into the community, so we can provide options often. So always feel free to reach out to our team. We can provide when we do know because we do collaborate. A lot of times, doctors are open to learning about eating disorders. So our nursing team at Within does trainings for them as well. That findedhelp.com is a helpful resource. Chrissy, what do you think?
You're
Any
hitting on the ones that I was going to say, but I
Yeah.
think eating disorder informed is wonderful. If it's someone who is younger, adolescent medicine typically is much more informed than general pediatricians. Um, but if it's an adult population, that maybe not. And so, um, I think one of the things is like Erin mentioned, are they willing to learn? Because what we have actually experienced is some of the providers that were early referrents to us were not eating disorder informed. They informed themselves because of patients that they had, and then their practice becomes inundated with eating disorder patients because when someone finds out this person knows what they're talking about, everyone wants to go to them. And so if they're willing to learn, we will provide resources for them.
Another question, what if a patient has not admitted or understand that they have an eating disorder diagnosis yet?
Mhm.
That's a big one that we see pretty often too.
Yeah. So, that's a very therapeutic question,
I
depending on, oh, go ahead.
Yeah, I was going to say a big part too is from the therapeutic lens is kind of breaking down the barriers and stigma around the language used.
Mhm.
Oftentimes, even taking the term eating disorder off the plate, literally, right? And just talking about behaviors and then leading into the scientific, what's happening to your body and using it as fuel, talking about a diet in general, like what do we eat and consume in a day? And then leaning into, your thoughts and fears and how that impacts your day to day. So taking that language aside and leaning into how it has an impact on your mind, body, and soul. Because when it comes down to it, right, it takes a while to get to that place if there's so much stigma and diet culture involved in it. So step by step and really leaning into reality testing and maybe not so much into the language used until they're
And
ready.
so, and sometimes with that, the medical piece, if they are experiencing any of these things that we talked about, can help to open their eyes to it. And if it's not them, I often say get loved ones involved also, because often the loved ones are going to be able to see things and point things out that the patient themselves may be more resistant to seeing.
Don't see any other questions right now. How about finding an ED-informed dietitian? Insurance often doesn't cover dietetic services unless diabetic, so affordability can be an issue.
Yeah, we see that too. And so a lot of times the dietitian is something that patients are paying for out of pocket. There's not a lot of insurance coverage when it comes to seeing a dietitian. So we, again, I know Erin has a list probably 8 pages long of eating disorder informed dietitians, which is important because, it is a nuanced work that is different than any other work that a dietitian is going to do. So you want to find someone who knows eating disorders.
Absolutely. All right. Well, I think that is it. Chrissy, thank you so much.
Of course, my
This was
pleasure. Thank you
really, really
everyone for
helpful.
coming.
And we will wrap up here. Possible to get contacts. Yes, I'm going to send out my email and you can respond and I can connect you with resources for dietitians, doctors, depending on your location. So keep an eye out for an email coming from me. All right. Bye, everybody.
Thank you, everyone.